Duty. Now we welcome David Simar from the School of Medical Sciences at the University of New South Wales, who's going to provide some insight into metabolic complications in childhood cancer. Welcome, David.
Thank you for the organization to giving me the opportunity to present some of the results that we've generated. So this is an ongoing collaboration between the School of Medical Sciences at NSW and the Sydney Children's Hospital, and we've got also some collaborators down in Denmark who are actually helping us with some of the molecular biology that I will be presenting here. That work was actually mostly done by Saga, who was my PhD student and was just graduated. That's a collaboration with Richard Cohn, who's a pediatric oncologist at Sydney Children's Hospital, Karen, who's a nurse in that department and who has helped a lot with the recruitment and looking after the patients, of course, and Romain Barres, as I said, who's actually located in Denmark. You probably all know a lot about those numbers here, the fact that in Australia we've got about 1 in 550 to 600 children who are actually diagnosed every single year with cancer. And the bulk of the population that we're actually seeing at Sydney Children's Hospital have actually been diagnosed with leukemia, and most of the time acute lymphoblastic leukemia. And due to your work, a lot of those kids actually survive their cancer, and about 85%, depending on the diagnosis, of course, will actually reach at least 5 years remission. One of the problems that we're now facing, and in particular Richard was being a pioneer, in fact, in looking after survivors, is the fact that you've got at least 2/3 of those patients who actually develop long-term complications. And one of the most prevalent complications that we're actually looking at here are metabolic complications. They can have different presentations, including obesity, sometimes hypertension, in fact, but most of them will actually develop insulin resistance and very early in life. Usually when you've got a mix of different risk factors, you might actually start developing signs of insulin resistance or type 2 diabetes around the age of 40 to 45. Here we're talking about survivors who have now reached the age of 20 to 25, and some of them have already developed clear signs of insulin resistance and type 2 diabetes. So that's very early. And of course, down the track, what's waiting for them probably by the age of 40 is cardiovascular disorders. So that has a huge impact on the quality of life, as you can imagine. There's been several reports across the world, not only Richard here in Australia in 2006, but also in the US. And in those populations, it's fairly common to identify the use of radiotherapy as a treatment as one of the major risk factors for the development of those metabolic conditions down the track. And in fact, as I mentioned to you, Richard's team in 2006 reported the fact that those patients who received irradiation were characterized by an increased prevalence of hyperinsulinemia, insulin resistance, or impaired glucose tolerance. So what we decided to do is to try to tease out a bit more what could be the mechanisms here, and upon identifying those mechanisms, then maybe we might actually be able to identify some early markers that could then provide us some opportunity to treat very early on those patients who are considered to be at risk. And so in that particular study, we recruited about 80 patients. They've all been on full remission for at least 5 years, and they have reached, on average, the age of about 25. And then we looked at what could be the critical factors that might actually be driving the development of insulin resistance in that population. Of course, what we found as significant risk factors were overweight or the accumulation of central fat or visceral adiposity, if you want. These have been described in the general population as playing a critical role in the development of insulin resistance. But what was striking was the huge effect of total body irradiation in the development of insulin resistance. So basically, someone who had received in the course of his treatment total body irradiation was 10 times at a higher risk of developing insulin resistance compared to the other survivors. So we then decided to look specifically into that subpopulation of our group and to try to tease out what could be the differences between those who received total body radiation versus those who only received chemo, for instance. We ended up having 14 survivors who had received TBI at some point in time versus non-irradiated, about 27. And when we looked at different parameters, whether anthropometric parameters or biological markers, for instance, the most striking difference, of course, was in terms of hyperglycemia and the prevalence of insulin resistance. Here, by the age of 25, we had already 50% who were considered to be insulin resistant. As I mentioned to you earlier, unless you've got clear risk factors like family history of diabetes, sedentarity, no physical activity, and being obese, for instance, you shouldn't have insulin resistance. If you look at that population, the BMI, which is below 25, which is a cutoff to be considered overweight, so that means that they don't even have that risk factor, but nonetheless they develop insulin resistance. So that's clearly suggesting that there's something wrong here. And when you try to tease out, there was a bit of a difference in terms of lipid profile, so potentially there could be something happening here, but that was probably not sufficient to actually explain why these kind of complications are happening down the track. My background is more into metabolic disorders, which means that for me, I kind of know what's happening when we're talking about obesity, or I think I know, but although there is general agreement to the fact that increase in visceral adiposity or inflammation are the two critical markers or the two critical mechanisms involved in the development of insulin resistance, we still don't really understand what comes first and how it really works. What was striking in that particular population of survivors was the fact that although those who received TBI had increased prevalence of insulin resistance, when we looked at what was their body composition, for instance, there was no difference. If you remember, their BMI was actually below 24, whereas the other group was at about 25. No significant difference between the two, but that also means that they haven't actually started to accumulate fat. So that actually led us to hypothesize that potentially inflammation might actually be playing a key role here. It's a bit complex, but just to summarize it, what we know about adiposity and in particular adipose tissues is the fact that it's a very plastic and dynamic organ. It's not simply composed of adipocytes, but immune cells are actually resident in our fat. In the context of a lean individual, we've got a particular type of cells that are present here, and mostly these are lymphocytes, but you also have macrophages, and they have a particular profile. But when you start to accumulate fat, something might be happening to our adipocytes that will actually completely change the environment. And in that condition, what's happening is the fact that you start to see accumulation of pro-inflammatory cytokines. So you start to see the emergence of an inflammatory process in our adipose tissue. So we actually looked at whether or not that pro-inflammatory environment might actually be present in those patients. And what we did, we measured a lot of different cytokines, but just to summarize it here for you, when we look at cytokines, you've got pro versus anti-inflammatory cytokines, and what was striking in that particular population was the fact that if you compare those who have been irradiated, who received total body radiation, to those who didn't, for instance, we found systematically a significant difference between those two groups, supporting a significant increase of pro-inflammatory cytokines. We measured tumor necrosis factor alpha, interferon gamma, interleukin-2, for instance, which are key pro-inflammatory cytokines, and they were systematically elevated in those patients who received irradiation. And when we pushed it a bit further and we tried to look at whether that could actually be linked with insulin resistance, and we used the HOMA insulin resistance index here to assess the severity of insulin resistance, we found that there was a significant correlation between the level of interferon gamma or TNF-alpha, for instance, and the severity of insulin resistance. And you can see the black dots here that actually represent those who receive total body radiation. So we are facing a situation where we've got survivors 10, 15 years down the track after full remission. They have cleared their cancer, but unfortunately it seems that one of the complications is that emergence of a pro-inflammatory environment that might actually be promoting insulin resistance. I mentioned to you the critical role that leukocytes play in the normal function of adipose tissues, for instance. And upon developing obesity, for instance, the entire environment and the entire profile of those cells dramatically change. And what happens is that, as I mentioned to you, you get an increased level of pro-inflammatory cytokines, and the source of those cytokines can actually be variable. They can come directly from adipocytes that are suffering from hypertrophy, for instance, or reduced oxygen availability. They could also come from macrophages, but more importantly, they can actually come from lymphocytes, T cells. And so that actually led us to look at whether or not there was something going wrong with the T cells in those patients who received total body radiation. Using flow cytometry, you can, from whole blood from a patient, you can actually isolate lymphocytes, and you can use specific markers that will allow you to see which type of cytokines those cells are producing. And what we did, we looked at T helper cells, and we looked at T cytotoxic cells, so CD4s or CD8s, and we look at the type of cytokines they might be producing. IL-4 is an anti-inflammatory or type 2 cytokine, whereas interferon gamma is a pro-inflammatory cytokine. And not surprisingly, what we found was the fact that those who received total body radiation were actually characterized by an increased percentage of T cells that tended to synthesize pro-inflammatory cytokines. In terms of the mechanisms that could be driving this, we know that it all comes down to intracellular mechanisms. So basically how particular events or particular clues in the environment around those cells might actually drive certain mechanisms that will result in the synthesis of those cytokines. And we know that amongst those pathways, we know that, for instance, P38 or PS6K1 are critical molecules. If they get activated, that means that your T cells will secrete pro-inflammatory cytokines. And then again, when we compare the two groups, what we found was the fact that if we compare the TBI group to the non-irradiated group, we had a significant difference here in terms of P38 activation of PS6K1 activation under resting conditions, but also under stimulated conditions. So clearly, those cytokines come from the fact that for some reason, the immune system in those TBI patients, in those survivors who receive TBI, seem to actually be skewed towards a more pro-inflammatory phenotype. When we try to identify what could be the mechanisms that's driving this, you've got two ways of doing that. If you think about it, you receive a dose of irradiation. So what could be happening is that potentially your cells directly receive the impact of the irradiation, and that might actually affect their function. Or they could actually be just responding to some environmental cues. For instance, irradiation might induce inflammation in the adipose tissue, and those leukocytes resident in the adipose tissue might be responding to that particular environment. When we directly exposed lymphocytes to irradiation, we didn't find any significant effect. Although it seems that there is a trend here, we couldn't find any significant difference with different doses of irradiation. So clearly, direct irradiation of those cells might not be the critical factor here. The other experiment that we ran here was we irradiated adipocytes, and then we collected the culture media that they were cultured into, which means that that would actually capture all the molecules that those adipocytes that have been under stress might actually be releasing. And then we cultured the lymphocytes from healthy donors in that particular media. So basically we're trying to tease out what does the environment within the adipose tissue might be doing to the lymphocytes, to our immune cells that are resident in here. And what we found strikingly was the fact that if you culture lymphocytes in the culture media from adipose tissues that have been exposed to irradiation, what you found is an increased activation of those signaling pathways that have shown you to be involved in the synthesis of pro-inflammatory cytokines. So basically you could be facing a situation where because your adipose tissue has been exposed to irradiation, it might actually change the environment here, and that might actually drive that inflammatory process later down the track. Of course, because most of those aspects were actually observed 10, 15 years after the irradiation, that tends to suggest a memory-like effect. How can our body memorize a stressor? How can it memorize any kind of experience that we might have been exposed to when we were younger? DNA, for instance, could actually carry some damage that were due to the irradiation process itself. But another aspect, another mechanism that's quite important is what we call epigenetic. Basically, how do we read our DNA sequence? Basically, every cells in your body more or less carry the same kind of information. The fact that's going to determine whether they're going to turn into an adipocyte or a muscle cell, for instance, is how you're going to read that sequence. And epigenetic is one of the key mechanisms here. And a couple of years ago, both Roma and myself, we actually showed that in the context of metabolic disorders, obesity or insulin resistance, for instance, we can actually observe epigenetic changes, which means that the way our cells are actually going to read the DNA sequence is going to be impaired. And that might actually have dramatic effect on how they then function. And what's interesting is the fact that DNA methylation, changes in DNA methylations have also been reported in response to irradiation. So we then looked into the same patients whether or not those changes in DNA methylation could actually be observed. And although we didn't see anything in lymphocytes, monocytes, or B cells, we found that T cells, those same cells that we showed were actually adopting a pro-inflammatory profile, were actually characterized by hypomethylation here, which means decreased methylation of DNA. So basically that was actually showing the fact that there is an association between being exposed to irradiation, developing metabolic conditions, and that association could actually be driven by epigenetic changes. To summarize, in that particular study and in their previous study, they actually, our collaborators showed that there is an increased risk of metabolic disorders in cancer survivors who have been treated with irradiation. What we showed here was the fact that in those survivors, we found increased insulin resistance, but that's also associated with increased inflammation. And we know that inflammation, even in a general population, is a key mechanism responsible for the development of insulin resistance. That systemic inflammation seems to be due to a modification in the intracellular signaling in lymphocytes that might actually be driving them to synthesize type 1 or pro-inflammatory cytokines. And that seems to be due to a bystander effect. That's not a direct effect of irradiation, but rather a response to the environment. And that could actually be linked to a unique epigenetic signature. So good and well, but what do we do about that? And what do we do with this when we're actually dealing with our survivors? The good thing is the fact that we've been able to identify some clear markers. There are some clear differences in terms of how certain cells in cancer survivors who have received total body radiation are behaving. And we have identified specific markers that would allow us to distinguish them from normal cells. One of the benefits here would be the fact that we could then actually validate those markers as early signs of the development of insulin resistance. By the time you've developed insulin resistance and you can measure it from a blood sample, that means that your adipose tissues, your muscles, as well as your liver, are already dysfunctional. We need to act before we actually reach that level. And that's what those markers could actually allow us to do. To finish, I'd like to thank all the contributors here. So Saga, who actually did most of the work in the lab. Richard, who's been looking after that cohort of survivors for about 25 years now. He's been a pioneer, as I mentioned, in New South Wales, as well as Karen, nurse who's been helping us a lot. Some of my colleagues at UNSW, as well as the entire group from Rome in Denmark. And none of this could have been done without the support of the Cancer Institute, the Cancer Council, the TCRN, as well as the University of Copenhagen and the University of New South Wales. Thank you for your attention.